So this lunch plenary was sponsored by Safe Movement. Be sure to check out their exhibitor table, talk to them, see what's up. They're really cool. As you all know, technology is everywhere, and telehealth especially will be a huge impact in the health field in terms of connecting with others, more accessible resources, and getting the needs when you need them, getting the services when you need them. Ryan, what are some ways that you're excited about telehealth?
Thanks. So I used to work at an organization called the Center for Sexualities and Health Disparities. I think 2 of them are out there. And I was introduced to kind of a pioneer system they were working with that provided telehealth HIV/AIDS testing to young youth all across the U.S. And I had never heard of telehealth before, and I didn't really know what that meant. But after reading more and kind of hearing more about it, I think it's really unique that you can do something as simple as an HIV test in your home with the comfort of your surroundings. So I think it's an awesome field that is going to continue and advance within the next few years.
Yeah, I'm also really excited about personalized telemental health and finding providers that are like you that may have some expertise in the things that you're looking for, such as LGBTQ friendly or immigrant status. So as you all know, technology is great, but what is it? What does it take to get there? What's the evidence around telehealth? To answer these questions and more, I'd like to invite our moderator and panelists to the stage. They're here. Our moderator is Dr. Jeffrey Klausner, who sits on the YTH Board of Directors and is the original co-founder of YTH. Let's welcome them.
All right, thank you very much, and I want to thank our dial-in audience. So we have a dial-in audience for this live broadcast, and we have participants from the U.S. Centers for Disease Control, from the World Health Organization, from the United Nations AIDS Program, and we also have different participants from different universities around the country, and obviously our wonderful YTH Live audience and our panelists. So what we're trying to do is really showcase the potential of telehealth for biomedical HIV prevention. And I'm going to pull up my slides. Okay, so I see different slides up here, so we have different slides here. And now being an academic at UCLA, I'm particularly interested in what is the evidence base for bringing forward tools to have an impact on people's sexual and reproductive lives. The Team Klausner Saving Lives is a team of young people, a lot of people in their gap years, also kind of medical school students and public health students at UCLA who are committed to working together to find innovative solutions and, importantly, test those solutions in different settings to have an impact on sexual and reproductive health. We know now in the United States there are about 37,000 new cases of HIV reported every year in the United States. The majority of those are in men who have sex with men, and particularly African American or black men who have sex with men. So it's still a significant disparity, an important population that we need to come up with new innovations on terms of how to reach. And you can see is primarily affecting, in terms of new HIV infections, young people. So people the age of 20 to 29 have the highest number of new cases of HIV in the United States. Our current control strategy can be essentially distilled to a biomedical paradigm. There's still important work done on looking at the social determinants of HIV, but it really, in terms of what the CDC and what most states and local health departments can actually do, is they can focus on testing, getting people on treatment as soon as possible, and then offering people PrEP or pre-exposure prophylaxis for biomedical prevention. So PrEP was first approved by the FDA in July 2012. So now we're more than 5 years after the FDA approval of this medication. However, only between 6 and 8% of those who actually need PrEP in the United States are using it regularly, and it's certainly not reaching those who need it most for HIV prevention, primarily black, gay, and bisexual men. So it's important, and part of the reason why we created YTH and its predecessor ISIS was to try to capitalize on these newer applications of information communication technology. So they're ubiquitous, they've been highly leveraged with substantial return on investment in terms of the business field, but we're still at the dawn of really trying to see the impact of it for health. And we started this work way back when in 1999. So back in 1999, we first recognized that we needed to meet people with credible information through sexual health websites. And a few years later, almost every health department and a lot of clinics, it was very basic to have websites with the hours of availability, the types of services. And over the years, we've explored different ways that the CDC has adopted internet partner services to reach people, to do partner notification. ISIS came up with a great program called InSpot, or Internet Notification Activities. And that went on to think about how can we reach people in the community, so in their homes with self-testing, self-collection of specimens for STI diagnosis, online programs for syphilis testing, and even for emergency contraception as well. So in the early 2000s, you could not walk into a pharmacy and get emergency contraception, and the only way was to walk in with a prescription. So we set up an online program where people could actually print out a prescription and then in the state of California take it to a pharmacy. And in addition, different kinds of sexual health messaging programs such as Sex Info, which was one of the first programs in the San Francisco Bay Area to be able to do proactive outreach to those at risk to inform them about where to get sexual and reproductive services. More recently, we put HIV self-tests into vending machines. And a couple weeks ago in China, released a report that they're putting HIV self-test kits into vending machines at universities, and at least at University of California, at UC Davis and UCLA, they have vending machines now on campus with the HIV tests, with Plan B, with contraception, and other reproductive health tools. We did studies showing that people not only were willing to use these self-tests that they collected from vending machines, but they would go get treatment. And that's been a gap in a lot of our internet and technology-based programs, is measuring actually impact. And you have to show funders, well, not only do people use it and do people like it, but what is the impact on the goals that the funders care about? Another example is the use of social media to promote HIV testing on Grindr sites. And through this program, we're able to show that through advertising and promotion on Grindr, people would request a home-based self-test kit for HIV, use that test, and those who are positive, and about 4% in that study were positive, would actually go get medical treatment. SAFE is somewhat of a new vision, and this luncheon and the lunches you're enjoying are supported in part by SAFE, where there'll be partnerships with the major geosocial networking applications and internet sites where people meet new partners, and the SAFE app would actually be integrated in that, so people could share their test results, people could access secure HIV and STI testing through laboratories, and then those test results would be fed back into users' profile in a secure way that they could not be corrupted or misused by any potential users. And you can learn more about that at the SAFE website. But switching to telehealth, where we want to use electronic information to support not just medicine, which is the care of individuals, but public health, which is potentially prevention interventions that are going to impact the health of communities. And what you always have to think about when you're dealing with any kind of interventions is how are you going to bring this to scale? And that's what some of the other presenters are going to share with you today, is actually scale at the state level and scale at the national level. So YTH and I started off with a small demonstration project a few years ago funded by Gilead. We wanted to see, okay, was it feasible to make an online telehealth program for young men of sex and men of color in the Bay Area who were either felt too stigmatized to go into sexual health clinics, too ashamed to speak to their medical providers, or just were not ready to be out and open with their sexual identity, but they could use an online service which they felt would be private, somewhat anonymous, and stigma-free. So PrEP Tech was also implemented in a different way you're going to hear about in the state of Iowa, and really focus on rural communities in Iowa where people may have to go hours to access a medical center, a site where they can get medication. And then you're also going to hear from folks at plushcare.com, which is really the national version. So we shared information from a local Bay Area program called PrEP Tech, to a state-based program, Iowa TelePrEP, to a national program called PlushCare. And then we have a speaker who's going to be joining us through our live feed from Washington, D.C. So Renee is a policy expert who's going to be talking about the landscapes and regulatory issues with telehealth. And then we're going to follow with the 5 of us with a panel discussion for questions and answers. So that's an overview of kind of today's plenary session, and I want to thank you for your attention. And now we're going to introduce our next speaker. All right, we're going to introduce our next speaker. Okay. Who is Cara Silva, who's the program manager extraordinaire who helped us really launch and implement PrEP Tech.
Good. Fantastic. Good morning, or good afternoon. Thank you, Jeff. My name is Cara Silva, and I am the Director of Programs at YTH. And I'm excited to introduce to you today a digital resource called PrEP Tech, a telehealth solution developed by YTH to provide PrEP access, adherence support, and stigma prevention for young gay and bisexual men of color. Before we begin, let me tell you just a little bit about YTH and who we are and how we got here. So the audience may first know us as the people who put on this fantastic YTH Live conference. We are also a nonprofit organization founded in 2001. One of our co-founders sits here. Our headquarters are just across the bay in Oakland, California. Our reach is local, national, and global with the work that we do. Our mission is to advance the health and wellness of young people through technology and innovative solutions, and we do this through our 3 pillars of work. Oops, on the right, sorry. Through discover, innovate, and lead. Through formative research, we do a deep dive with young people to discover what works. We then use youth-centered health design to develop innovative solutions for young people. And lastly, we lead. And we lead by sharing our findings and our learnings through capacity building assistance, through research, trainings, and at our National YTH Live Conference. The PrEP program I'll be describing today was developed by YTH in response to the slow uptake of PrEP among gay and bi men of color, to help them navigate the system, to access PrEP without the stigma and address some of the barriers that are currently related with the current system. The project is called PrEP Tech. PrEP Tech is an online management, PrEP management tool to provide PrEP access, adherence support, and stigma prevention for young gay and bi men of color. The PrEP Tech system was developed by YTH in late 2016 and was piloted through an IRB-approved study. The program users are both young gay and bi men of color, as well as their health providers. The PrEP Tech program is available through a HIPAA-compliant website that can be accessed via a computer and/or a mobile device. To make PrEP Tech inclusive and effective, YTH worked closely and recruited a community advisory board and a community intern. These folks helped guide us in the process from design to recruitment. And all men on our community advisory board, or CAB, identified within the gay or bi community. From informing the app's appearance and functionality to evaluating the appropriateness of the content, the CAB provided this input to make sure that PrEP Tech is confidential, stigma-free, and easy to use for people in their community. Here's a comic strip from our site that explains the main steps involved in PrEP Tech in a community-friendly way, of course, from registering to laboratory, telemedicine, medication, and adherence. I'll go into this a little bit further. But I do want to take a moment just to show you a little bit of our design process, and you can kind of see where we started and where we came from. So on the far left here, you can see some of our initial handwritten sketches of the design. And we've gone from, extremely rough sketches to our final product here on the far right. Based off a lot of our community advisory feedback, some provider input, as well as a review of literature and current apps, we moved from actual photos on the site to more of a cartoon-friendly approach. And we also identified that we wanted to decrease the amount of text involved in the site, and so we moved towards this comic strip section here, which has had a few iterations, as you can see as well. The PrEP Tech study was, and the site kicked off in late 2016, November of 2016, and wrapped up in March of this year. All of our information is HIPAA compliant, and it's stored online as a digital file on our encrypted server. This lowers the chance of hackers or outside people being able to find participant information. We also used encrypted emails through Powbox in order to make sure that each participant email was safe and secure and also difficult to hack. I won't have time to go through the entire site with you today, but I do want to highlight some of the main features. I'll go through them here. So with PrEP Tech, the client can determine eligibility and register online. So this is all done through our online eligibility form that takes a basic assessment of risk and status. The registration is done online as well using our HIPAA-compliant website, where clients can create their own personalized account to be able to log in and manage their PrEP. The PrEP Tech system also serves as an online educational tool. There's an interactive quiz, and this has been proven to be helpful to help clients and participants think through potential questions that they may have when they actually chat with their medical provider via their telemedicine appointment. So this is not an optional part of our system or the website, and participants are required to learn, and they're required to complete the quiz successfully before they can move forward in the process. And this is where participants get to know a little bit more about PrEP, what to expect, what some of the potential side effects might be, and how to manage their daily medication. Next, our participants receive a testing kit in the mail for home collection via the PrEP Tech system. The current kit includes 2 swabs for gonorrhea and chlamydia testing, self-collection and testing, a PDF lab order and digital link for your smartphone access, and a laboratory locator so you can identify the closest laboratory to go have your blood drawn. And home collection has eased patients' comfort and decreases the time required in the laboratory. Clients receive daily medication reminders via text, voice, and/or email, and these are customizable. The item on the left here is an example of a basic SMS reminder, and the item on the right is an email reminder. And each of these are basic examples, but every reminder is customizable. So users can decide how they want to receive the reminders via SMS, an email, and/or a voice, or they can also decide what the message actually says. So here on the left it says, don't forget to take your PrEP, but someone could easily do something in code, don't forget to call your mom. And we found that this has been particularly useful for people who don't want other people to know that they're on PrEP or may have some safety or privacy concerns at home. So I do want to talk a little bit about our medical providers and how PrEP tech is useful for them. You may recognize this provider here. It's before he grew his hair out, Dr. Klausner. With PrEP tech, our medical providers can actually schedule their telemedicine appointments for patients, get copies of the laboratory results, initiate appointment reminders, and order PrEP to be delivered to the patient's home. And for the other side to the coin is that for patients this is advantageous because with PrEP tech this eliminates their need to actually have to go in for in-person doctor visits. It no need to travel to a clinic, pay any transportation fees, deal with any time off of work, and just the ability to connect with a provider in the comfort of your own home if you so desire. So that's a quick overview of some of the features of PrEP tech, and now I just want to take a few moments to share with you about our study. So this was, as Jeff mentioned, a pilot study. This was an opportunity to give it a shot in kind of the San Francisco Bay Area. And as I mentioned, this is an IRB-approved study. All participants in our study received lab testing at baseline and 90 days. They received 3 30-minute telemedicine appointments with a UCLA medical provider, a 3-month mailed supply of Truvada at baseline and 90 days, custom daily adherence reminders, as well as weekly SMS health tips, and a behavioral participant satisfaction adherence survey at 30, 90 days, and 180 days of the study. The participants were recruited through Grindr, Craigslist, social media, and in-person recruitment with our community intern. So you can see a copy of one of our posters here, and these were made into flyers and posters and hung up in local community places. PrEP tech was administered as a longitudinal study between November of 2016 and May of 2017, where we recruited 25 HIV uninfected young MSM, age 18 to 24 years, in the San Francisco Bay Area. 84% of our sample were participants who represented or identified as MSM cisgender men of color. 21 or 84% of our participants completed the 180-day study, and 4 people dropped out of the study mid-study. Post-study, PrEP tech or YTH staff assists with each of the participants in the continuation and transition to permanent PrEP care. And of the 21 participants who completed all 180 days, we had 16 of the 21 who were interested in continuing PrEP, 5 who were not interested in continuing. 11 of those were successfully transitioned to permanent PrEP providers. 3 were in the process of transitioning when we closed the study. And 2 participants were relocating out of the San Francisco Bay Area and opted to wait until they had found permanent residency before they sought out a PrEP provider. And here's a little bit of feedback from our 90-day assessments of the study. So all of our 21 participants actually agreed that the PrEP tech program, compared to other forms of getting PrEP, is either very or extremely convenient. A majority of the participants also noted that the PrEP tech program is a better way to get PrEP than going into a doctor's office, with 86% of folks either agreeing completely or agreeing slightly. And as you can see, the majority of participants noted that the PrEP tech program helped them to feel confident in their ability to protect themselves from HIV transmission, with 95% of the participants agreeing that was very or extremely helpful. And lastly, the majority of participants noted that the PrEP Tech program helped their medication adherence, with 76% of the participants agreeing that it was very or extremely helpful. I also want to take a few moments to just share a few quotes from participants with some qualitative feedback. So this participant noted that PrEP Tech has allowed me to access PrEP in a way that would be otherwise difficult, stigmatizing, and expensive. It offers a confidential feeling, and the daily reminders are definitely helpful of keeping track with the medication. Our next participant noted that being open about accessing PrEP is why I really enjoy PrEP Tech. There was no ambiguity or concern as to whether I would be approved so long as my diagnostics came back compatible. The first time I talked to a regular doc about the issue, she basically shamed me and tried to scare me into celibacy, which is an unfortunate experience. A few more folks. So another person here really liked the easy appointments and the deliveries of materials, noting, quote, "It's an easy program that gives the opportunity to experiment with PrEP. They will remind you when you need to take your meds and connect you with sources of support." Another participant really loved having access to the medication and to Dr. K, and mentioned that his observances were definitely necessary. And the last one I'll highlight, it regarding PrEP Tech removes a number of barriers that seem small but add up, like scheduling doctor's office visits and taking off of work and going to the pharmacy. So next steps for the PrEP Tech program. So as we've been evaluating the pilot study, the response has been positive, and we're beginning to disseminate the findings as we're doing here today. YTH hopes to initiate a phase 2 of the pilot that will scale PrEP Tech to a larger region, statewide or nationally, to provide more evidence. And lastly, recognizing the needs of the transgender youth population, their lack of representation in a lot of mainstream studies, as well as a high prevalence of HIV transmission compared to cisgender people. We really want to take this opportunity to adapt and test PrEP Tech to include the transgender community in the future. And we look forward to sharing that. I want to take a moment just to thank the important people who've helped to make this possible. I want to acknowledge from the generous support of Gilead Sciences to our medical partners, Dr. Jeffrey Klausner and Mabel Kimball at the UCLA School of Medicine, as well as our engineers at Savion's Healthcare. And with that, I want to say thank you. Please feel free to contact any of my colleagues here on the slide. Thanks.
All right, excellent. Well done, right on time. So we're doing great there. And now I'm going to introduce our next speaker is Dr. Michael Ohl from Iowa. And we just learned recently that Michael and I both trained together at University of Washington. And as we move from a regional pilot program, now we're going to hear about a more extensive state-based program and how it's implemented within the state of California. So thank you, Michael, for joining us.
Thank you, and thank you to all of you for the opportunity to be here today and talk about our experience with Iowa TelePrEP, delivering PrEP through telemedicine and public health partnerships. So these are my disclosures and funding sources. So Iowa TelePrEP is rooted in partnership between the Iowa Department of Public Health, the University of Iowa, and community members. And I'm here on behalf of our entire team presenting, and we have a shared mission to make it easy to get PrEP everywhere in the rural state of Iowa, and within that a vision to make every county public health department and sexually transmitted infection clinic in Iowa into a point of same-day PrEP access. So rural areas of the United States, roughly speaking the dark areas in this nighttime satellite image, comprise 97% of the U.S. landmass, 18% of the population, 6% of people newly diagnosed with HIV. So rural populations are, by definition, small and dispersed. If they weren't, they'd be urban. But rural populations matter from the perspective of HIV prevention and PrEP scale-up. There are rural counties in the southeastern United States with HIV incidences compatible or comparable with those in the highest incidence large cities. Recent outbreak of HIV in Scott County, Indiana, and smaller outbreaks in rural areas show the potential for rapid spread of HIV in rural areas impacted by opioid use, evolving patterns of intravenous drug use. Even in the low HIV incidence upper Midwest, where I'm from, rural populations matter in HIV prevention. So in urban Chicago, about 400 square miles, there are roughly 1,000 new diagnoses, people newly diagnosed with HIV each year. If you look at 7 surrounding mostly rural and small urban states, and just at the rural and small urban cases, I mean that urban areas smaller than 500,000 people, there are about 1,100 a year. So a comparable number of people diagnosed in rural and small urban areas as in Chicago, but rural and small urban areas are spread over 400,000 square miles as opposed to 400 square miles of Chicago. So clearly we can't establish a PrEP program in every rural community. We need something that scales up in geographic area covered to reach large numbers of people at risk without accruing large additional costs as geographic area increases. So telehealth comes to mind. But what does that look like? So one other question that I'm frequently asked is, Iowa? Really? Do we need to talk about PrEP in Iowa, in rural Iowa? Are there really that many people with need? And we have some data from the Iowa Department of Public Health that sheds some information on this. So in 2016, IDPH started screening for PrEP indications amongst clients served in public health affiliated programs statewide. And those programs included county public health departments and sexually transmitted infection clinics, of which there are approximately 60. In disease intervention specialist and partner services programs. So in Iowa, as elsewhere, if a person has a reportable sexually transmitted infection, HIV, gonorrhea, or syphilis, these are the individuals who will contact that person, make sure they're linked to care, contact their sexual partners, and make sure they're tested and linked to care as needed. Also, integrated testing services or HIV testing services. So this may be in public health departments, it may be in community outreach settings, street fairs. It could be in Walmart parking lots in rural areas where there's sometimes large groups of people living. And in 2016, in these settings, there were about 5,600 people with indications for PrEP in Iowa Department of Public Health, of whom about 1,000 or 19% were rural dwelling. If we look at indications for PrEP amongst those rural dwelling Iowans in public health settings, it resembles that we see in the United States overall. So about half are men who have sex with men with additional risk factors for HIV. Approximately a quarter are people who are using IV drugs, and we're seeing more of that in rural Iowa as in other rural areas in the United States. And approximately a quarter are heterosexual men and women with additional HIV risk factors. So I think what this shows us is that there are potentially large numbers of people in rural Iowa with need for PrEP, both within public health settings and outside of public health settings. But it's hard to get PrEP in rural Iowa, and this vignette illustrates that. So this vignette is really an amalgamation of situations and people I've chatted with in recent years. So that is a 42-year-old gentleman, sexually active with men and women. He does not self-identify as gay or bisexual. He's in a long-term primary relationship with a woman. Sex with men occurs infrequently with inconsistent condom use, and he lives in a rural community in Iowa with a population of 2,000. He worries. He worries about his own HIV risk. He worries about his partners and potential HIV risk for people he loves. So he travels 100 miles each way to a public health clinic in a somewhat larger city in Iowa for testing, bypassing more nearby sites for testing because he doesn't want to disclose his risk and because it's a very stigmatized issue locally. So when he goes to a distant public health setting, PrEP is recommended, but he's reluctant to discuss PrEP with his local provider for reasons of stigma, privacy. So really key rural barriers to PrEP access in rural areas include stigma, privacy concerns, which are an issue everywhere, long distances to provider, and just there aren't many providers in rural America in general. Rural areas tend to be healthcare provider shortage areas. There aren't many providers of any kind, let alone PrEP providers. So how do we overcome these barriers? Where do we start? This is what we were faced with a little more than a year ago, and it seemed overwhelming. And I always like this quote from Arthur Ashe: start where you are, use what you have, do what you can. So in the spirit of grassroots, bottom-up program development, a group of us got together and said, okay, where are we, what do we have, and what can we do? So we included representatives from the Iowa Department of Public Health, University of Iowa's HIV program, community members who'd been working to get PrEP in rural Iowa and running into barriers. And we said, what do we have? Well, we have the existing built-out public health programs that I already mentioned, public health clinics across the state, et cetera. We have resources in our own HIV care program. We have telehealth platforms, which are being used for other indications. How can we put these together? We did stakeholder interviews. We talked to people who would be users. We talked to people in the public health setting who would be involved in delivering this, healthcare providers. We tried to understand people's needs. And then we started prototyping possible solutions and putting together these resources together with Johnson County Public Health. So this was a human-centered design approach to validate assumptions about what people needed and what they would be willing to do in rural Iowa. And this is what we came to, in summary, the Iowa TelePrEP model, and it's more than just telemedicine. So we identify individuals with need for PrEP using 3 strategies. The first is in the public health programs I mentioned, sexually transmitted infection programs, partner services program, testing services, where there's screening for PrEP indications. We market on the Iowa TelePrEP website through banner ads and geosocial and sexual networking apps. We have ads on Scruff and now in Grindr. We do outreach to providers in rural Iowa. And then people are linked to a telephone navigator. So this is an attempt at comprehensive linkage to services to assess needs. Navigation around getting to PrEP, signing up for insurance. Iowa's a Medicaid expansion state. The Gilead Medication Assistance Program, linkage to substance use care, whatever the services are that are needed. The next step is a video chat, a virtual visit using an off-the-shelf, generally available video conferencing app called Video, which is a secure HIPAA-compliant app. So these are visits with clients in their homes, in their cars, wherever they want to be, private visits. And these are with pharmacists in our program, as I'll mention in a minute, for comprehensive discussions around PrEP. We link people to, currently our model is public health affiliated labs in Iowa, where they can go for blood work to obtain their own swabs for sexually transmitted infection testing, very similar to what you just heard about. And then we'll mail people PrEP in a discreet way to P.O. boxes, to their homes, to their work, wherever they want it. So the goal is to get people PrEP without having to see a doctor in a way that overcomes barriers related to distance and stigma. So as I mentioned, the visits are with a pharmacist. We do this through a pharmacist collaborative practice program, which a number of states will allow, as you see in the map on the left. So this is physicians and pharmacists working together. One of our main barriers where there just weren't enough providers to do these visits in various Iowa settings. So we set up through our Pharmacy and Therapeutics Committee a protocol where pharmacists will do these visits working with physicians according to guidelines, creating formal relationships. We create a registry for population management within TelePrEP. And then these pharmacists have worked in our HIV program, so they have a lot of experience around counseling for risk reduction and adherence management. So this is a comprehensive visit. This is the network of public health affiliated laboratory sites in Iowa. People can go and have their blood drawn, they obtain self-swabs for sexually transmitted infection testing. And critical part of this partnership with public health is not only client identification, but when people test positive for sexually transmitted infections, we partner with the public health partner services to make sure they're linked to care locally in a way that they're comfortable with for the treatment for sexually transmitted infections. We're now moving towards home-based testing entirely, with all blood and sexually transmitted infection swabs can be mailed to us. So TelePrEP really isn't a single thing. It's a bundle of simple, cheap, easy interventions put together in a system, and each part of the bundle should overcome one of our barriers. So around stigma and privacy concerns, we try to do visits in a private way wherever people want to be. Discrete medication mailing, the same interventions can overcome barriers related to distance. And then the Pharmacist Collaborative Practice program allows us to get around some of these issues of physician shortage and provider shortage. I don't like the term task shifting. I prefer to think of it as task sharing, so interdisciplinary collaboration to increase our capacity. So this is some data from our local pilot with Johnson County Public Health, trying to work out some of our protocols before scaling. So we had 103 referrals in approximately the first year as we worked through this, about half from public health and a half elsewhere. Of those, 81% completed a video visit within 2 weeks. Amongst those, 94% started PrEP, and our 6-month retention by visit completion was 87%. So amongst these clients, 15 had a newly identified sexually transmitted infection that was not part of the reason they entered PrEP in the first place, including 6 with syphilis, 4 with gonorrhea, 10 with chlamydia. Most were extragenital infections. So the importance of people swabbing, obtaining throat, rectal, vaginal swabs for STI screening and telemedical PrEP programs. 1 pregnancy identified in a client at high risk for HIV infection in a relationship with a man who was positive and not on meds. And we also send out vaccine orders to pharmacies locally for hepatitis A, B, and human papillomavirus infection, which is, from a public health standpoint, a large part of our program. So now, in recent months, we've been working to scale up statewide, and we're doing this as an experiment, as a quasi-experiment, if you will. And like many states in the middle, Iowa is conveniently rectangular. And what that means is we can take our public health regions, of which there are 4, and divide them into TelePrEP regions, because we can't scale efficiently simultaneously everywhere, and we've scaled in the east. And so people in public health there have access to public health clients have access to TelePrEP. In the western half of the state, we're working with navigation and community PrEP providers. And then we enroll people in the public health setting, and we follow them up through internet surveys, phone calls, medical record review, to follow them through the PrEP continuum. Do they initiate PrEP in 30 days out of public health? Are they retained at 6 months? Does TelePrEP make a difference? As Jeff mentioned, we have to show impact at population and state level. So one of our goals is for people to have no out-of-pocket costs for their TelePrEP visits. Our clients don't have a lot of cash. A lot of people don't have a lot of cash, and this is a major barrier. So we're trying to think about how to keep these visits. We currently have some support from public health free to the client going forward, and our business case for that is we have a parity law in Iowa. You'll hear more about the payment for telehealth programs later, so that will hopefully soon allow us to bill insurers when present for some of the visits. Our pharmacy that we mail Truvada for is through as a 340B provider, which means sometimes there's some margin from the pharmacy that we can use to support the program. Also, we can use public health programs and state labs that already exist and their tests of public health significance to pay for some of the laboratory studies. So in conclusion, Iowa TelePrEP is a bottom-up grassroots program that took existing interventions and bundled them together in a different way. We tend to think about tech and app development, but what we did was really take partnerships in communities, put them together, and think about how do we use off-the-shelf technology and wire them together to create a network. Pharmacist collaborative practice can overcome PrEP barriers related to provider shortages in rural areas. And then lastly, public health partnerships, I think, are essential to think about in telemedical PrEP programs, both for client identification and for efficient linkage of clients with newly diagnosed infections back to treatment as we scale up. Thank you for your time.
All right, thank you very much, Michael. It's great to see these kind of evolving models from the local community level to the state level, and that's why I'm very excited to be able to introduce Dr. James Wantook, who's one of the chief medical officers for PlushCare, which is a large national commercial enterprise which offers online telehealth services for a variety of different medical conditions. But I asked them just to speak specifically about their program for PrEP. So thanks for joining us today, James.
Can I take this microphone off? Yeah, good. Am I going to mess with your camera? I'm moving around. All right. So, as he mentioned, my name is James. I'm here today to talk about PlushCare. PlushCare is a virtual doctor's office. We're also a technology company. So we essentially connect patients with physicians virtually by video chat and by other communication means. So it's kind of the doctor's office for people who don't want to go to the doctor. And that's kind of how I sell it. So as you can see, we have apps available. Now, we started PlushCare because my co-founder and I believe that illness and disease are barriers. They're barriers to achieving your dreams. They're barriers to reaching your full potential in life. And it's hard to get many people, especially healthy people, excited about, going to see the doctor. It's just not a thing that people want to do. But when you do have a health issue, when you do have a problem come up, it presents a major barrier in your life. And nowhere is that more true than someone who's young and otherwise healthy and gets a major diagnosis like HIV. It eliminates or severely impacts their life in a way that it's hard to really comprehend. So, as I mentioned, the company, the medical practice is an app. Anyone can book an appointment with a doctor by downloading the app. You can see the doctor within minutes, who are all, well-trained, high-quality physicians who you can trust and who are trained in how to use this technology. And then the doctor can do a lot of things. We can send an order for a lab test. We can send a prescription to the pharmacy, to your local Walgreens or CVS where you can pick it up. We can even order x-rays, imaging, sending you down to your local clinic to get that stuff done. So for PrEP specifically, the process is pretty simple. We take the highest quality doctors in the country and the world who trained at the top medical schools and institutions in the United States, and we arm them with sort of the CDC guidelines for how to deliver PrEP, how often to visit, what to test for, when to prescribe, when to not prescribe. And we connect them with patients in currently 43 states. So we will be nationwide in all 50 plus DC by July is the goal. And patients can come to us for PrEP, find a doctor that is knowledgeable about PrEP, who is not going to judge them, who is trustworthy. And I think that's probably one of the greatest things that we offer. How are we doing? It's going pretty well. We started in late last year, and we're now probably well over 1,400 PrEP patients on our platform. We believe strongly in the getting to zero philosophy, and we want to play whatever role we can in doing that. How do we get these people? Where do we find them? We are where the patients are, on their phone, on social media, Instagram, Facebook. We're on Yelp. You can find us in the App Store. You can Google us. We try to be everywhere that you might find us. Our population is pretty diverse. People of all genders, races, ages, locations. We've got at least one of every kind of person. It is mostly young people, as Dr. Klausner mentioned. Probably our biggest method of attracting new patients is word of mouth. It's the strongest recommendation that someone can give. It's more powerful than any of these digital platforms. It's someone telling someone else, hey, I used PlushCare to get PrEP. It was great. That's where the majority of our people are coming from. So not only are we getting them enrolled and getting them on PrEP, but we're keeping them. So over 90%, I don't have the latest numbers, but over 90% of people that have a first visit have a second visit. And over 90% of those that have a second visit have a third. And that means they're getting lab testing, they're getting the prescription, and presumably they're taking it because they're coming back. And we have two advantages. We kind of have a secret advantage of being on their phone. That's the unfair advantage that we have. We can send them reminders. Hey, your labs are due. Your next visit's in a week. The doctor wants you to do this or that. And then second, we also take their insurance. So we're trying to be a network with every insurance company that'll have us. We've got most of the major ones. So almost anyone with insurance, Medi-Cal in California, can come to us and they just pay their copay, just your regular doctor's office copay, and then we help them sign up for copay assistance, Medicaid if they don't have it, connect them with any resources that we know of or that are available so that they're not having to worry about these things. And of course, none of this could be possible without the team. So we have over 50 physicians at PlushCare who are supportive, knowledgeable, compassionate, and are really the ones doing the work. And of course, we have the team behind the scenes. 4 of them are in the audience today. Software engineers, designers, operations associates, and of course, most importantly, our PrEP lead, Jonathan, who's over there in the checkered shirt. He is in charge of the whole program, and it wouldn't be as successful as it is without him. So I just wanted to thank him. And that is all I have. What you can do is, if you know someone who might be a candidate for PrEP, tell them about PlushCare. If you work for an organization that is in any way involved in PrEP, come talk to me. We're interested in partnering with public, private, governmental, whoever, if you can help us find more patients who should be on PrEP and aren't. So I want to thank everyone for your time, and thanks for inviting me to talk.
All right, thank you very much, Dr. Wontok and the PlushCare team. Thank you for coming today. So we're going to do our reach. Are we set up to reach out to Washington, D.C. and bring in Renee Takashi? Hello, Renee.
Hello, how are you? Can you hear me?
I can hear you okay.
Great.
All right. So is everyone happy with Renee's size? We'll have that small image of Renee in the corner there, and we'll have his slides. Perfect. That's it. All right, Renee. So we have an audience here in San Francisco of about, it's about 150 or so, and we have at least 90 telephones on the line from around the world, and we're excited that you're able to join us as an expert in some of the legal and policy issues with telemedicine. Looking forward to hearing your presentation of victories and challenges, and then you're going to join us online as a member of the panel.
Right. Thank you very much. So what I'm going to talk about in my 15 minutes, it's going to be very brief. Obviously, a lot of these issues are very complicated, and we could take a deep dive into a lot of them. But I just wanted to give you sort of an overview. So we'll start out with some definitional challenges. I will go through an overview of the federal landscape, an overview of the state landscape, especially given the fact that a lot of telehealth programming is multi-state, regional, or national. And then we'll talk a little bit about the future of policy and some policy recommendations I have. So we'll start off with definitions. And quite frankly, this is a confusing set of issues from a legal and regulatory perspective. The terms are used interchangeably. Telehealth, telemedicine, I've heard both today. Historically, telemedicine really was about the provision of actual clinical or medical services at a distance, and telehealth was everything else: provider education, patient education, sort of the non-clinical functions of distance services. But over time, the terms have really sort of morphed into sort of an interchangeable use. On this slide, I've presented what's the major stakeholders, the terms they use, and the way they define them. So really quickly here, for example, the American Telemedicine Association ironically uses the term telemedicine and actually has a very broad and expansive definition of what telemedicine is, and really involves any kind of medical information that's exchanged from one site to another via electronic communications. Medicare, on the other hand, particularly for reimbursement purposes, uses the term telehealth and really narrowly defines that term and limits it to two-way real-time interactive communications. So asynchronous communications, communications that don't involve video, for example, are not reimbursable under Medicare. I've also included some other definitions here, and you can see telemedicine and telehealth are used interchangeably. The states themselves have their own definitions of telemedicine or telehealth. Only Alabama lacks a definition for either. Just as we've talked about in the previous slide, states alternate between the terms telehealth and telemedicine. Confusingly, some states define both. And so you've really got to look at each state's definition to figure out whether or not you fall within the definition and whether or not the way you're providing services actually meets a standard of care. Many states, by the way, in their definitions restrict definition of telemedicine in terms of modality, and we're going to look at an example, two examples here that I pointed out just to show you the differences. One great resource for those of you who are interested in telehealth is the Center for Connected Health Policy. It's the federally designated National Telehealth Center. It operates under a grant from the Health Resources Services Administration, and it's really a clearinghouse of legal, regulatory, policy, and operational issues. It's sort of all things telehealth and telemedicine. One of the things it does is twice a year now, it issues a policy report and also does a 50-state survey. So for those of you who want to know a particular state's approach to telemedicine or telehealth, you can look at this report. One of the things this report points out is that, for example, live interactive video communication, regardless of the state you're talking about, mostly fits within the definition of telehealth or telemedicine. So if you're using live interactive video, you can bet that you probably are operating legally and are operating within the standard of care, considering that you're meeting other definitions as well. Interestingly, however, email, telephone, and faxes are rarely acceptable forms of delivery. I should have included text and secure and unsecure messaging as well. Most states specifically exclude those from the definition of telehealth or telemedicine, whatever term the state uses. And I think that's important to note, given the very myriad forms of telehealth models that I see. So sort of to put this into a realistic context, I have provided definitions from 2 states. Both happen to use the term telehealth, which is increasingly being used by the state. Here's Wisconsin's definition. And one thing to note here is they really would prefer a combination of interactive video, audio, and images that functionally operate as much as a face-to-face encounter as would be possible. So in other words, they're trying to recreate the in-person encounter through telecommunications. Interestingly, if you look at this definition, we talked about exclusions. It specifically excludes telephone conversations or internet-based communications between providers and patients. So secure messaging, for example, and emails would fall into this exclusion. Hawaii takes a different tack, and Hawaii's definition, again, they use the word telehealth. They're much more expansive. Not only do they specifically call out the 4 modalities that are acceptable, but they also give you examples of what's included in the term telehealth. So obviously we've got real-time video conferencing-based communication, but Hawaii also allows secure interactive and non-interactive web-based communications and secure asynchronous information. So they take a much broader view of what constitutes telehealth. And I think this definition is much more in line with some of the modern ways telehealth is being delivered around the country. So let's take a quick look at federal policy, and this will be, again, a quick overview of what's going on at the federal level. There are many, many agencies involved in some aspect of telemedicine. I've listed a few here. The Department of Defense does very interesting modeling vis-a-vis telehealth and has got real great data about the use of telehealth. Their TRICARE insurance program that covers military, both active and retired military service members, does now cover telehealth and broadly defines telehealth. Obviously, the Department of Health and Human Services has various agencies that touch on telehealth in some way. CMS, which is the Centers for Medicare and Medicaid Services, probably being the most prominent of these, and we'll get into Medicare reimbursement very shortly. The Bureau of Prisons and the DOJ obviously uses a lot of telemedicine to provide care. We've all heard about the great statistics from the VA and the work they're doing, particularly in the telepsych area. And then the Federal Communications Commission, which I'm going to get to in a second, they're doing some interesting work because part of what is forgotten about telehealth or telemedicine is you need great broadband connection in order to facilitate better use of it. There have been several advances in policy over the last year or two. For example, the Bipartisan Budget Act of 2018 that was signed by the president in February has a series of telemedicine-related provisions included in it. So for example, starting January 1st of 2019, you're going to be able to provide clinical evaluations of end-stage renal disease via telehealth, which has never happened before. Also starting January of 2019, some of the geographic and facility restrictions for Medicare reimbursement have been lifted for the evaluation and treatment of stroke. And the Medicare Advantage plan now is going to include telehealth as part of its basic benefit. The other interesting thing that happened starting and effective January 1st of this year is Medicare is now covering and making separately payable a remote patient monitoring code, which is never done before. And this is an interim step to greater remote patient monitoring reimbursement under Medicare. So that's a great advance as well. A couple of other things to point out here. Even the U.S. Department of Agriculture is involved in the telemedicine or telehealth game. They have a grant program as part of its distant learning and telemedicine program, which provides grants to various proposals that facilitate the greater access to telecommunications services in rural areas, including telemedicine and telehealth. And in particular, over the last 2 years, they funded grant programs addressing the opioid crisis, for example, and how telehealth can be better deployed to attack that crisis. The FCC Connect to Health program is really a series of initiatives by the Federal Communications Commission to better provide access to broadband access around the country, and they're working and figuring out ways to provide broadband to rural areas. Of course, with the repeal of net neutrality, it remains to be seen how that's going to affect broadband access. The last thing to point out here is there are various congressional bills that are making their way through the legislative process that really seek to expand greater deployment of telehealth and telemedicine programs. The states obviously have a role to play here simply because a lot of practice of medicine or nursing or other clinical professions are provinces of the state. The great news here is states have come a long way in the last 5 years and really now facilitate the use of telemedicine. So most states now allow the initial patient evaluation to occur via telemedicine. The sort of the laggard states, Arkansas and Texas, are now on board. So that really allows telemedicine to flourish if you don't have to do your initial patient evaluation in person. There's been a rise of parity laws, and these are laws passed in about 35 states in the District of Columbia that require health plans to cover telemedicine services if those same services would have been covered had they been provided in person. So it's essentially forcing plans to cover and reimburse for telemedicine. There's been a rise of licensure compacts, which are essentially agreements between states, or among states, I should say, that really facilitate physicians, nurses, and other professions being licensed in multiple states and really sort of remove some of the operational and administrative burdens of clinicians being licensed in multiple states. The good news here on this slide is that there's little enforcement activity vis-a-vis a lot of telehealth and telemedicine programs. I can think of a few sort of high-profile cases that occurred years ago, but for the most part, states are staying out of the way, so long as there are no egregious activities taking place, and very little malpractice activity. The last major enforcement action that I can remember was in 2009, in which a psychiatrist was convicted of involuntary manslaughter. But beyond that, and since then, there's been little enforcement activity of any note in the states. And then the other thing I was pointing out was there's little malpractice activity vis-a-vis telehealth on the physician side. The Physician Insurers Association of America did a 10-year study and looked back at a bunch of medical professional liability claims. And of the 94,000 or so they looked at, less than 200 involved telehealth or services provided at a distance. and only about 56 of those resulted in some kind of monetary payment. So we're talking about almost negligible malpractice activity. Now, of course, since less than 1% of all consults are done via telehealth or telemedicine, I expect this to increase as more and more folks avail themselves of telehealth services. All right, let me just quickly talk about the physician compact. And again, this is essentially a compact is an agreement among states. 22 states are part of this interstate physician compact, and it basically allows physicians to be licensed in multiple states. The way it works is a physician gets licensed in his or her state of principal licensure. A federal background check is done. And once that physician receives a letter of qualification, he or she can then decide which states that are part of the compact to be licensed in. So it really facilitates multi-state licensure. I think the last statistics I saw is that 6% of all United States physicians are licensed in 3 or more states. So practice is still very local, but things like the physician compact and the nurse licensure compact, which has been in place for a quarter century, I think really facilitate multi-state licensure, making it easy for telemedicine providers to provide services across the country or at least regionally. So let's talk quickly about policy futures and why telemedicine expansion may be difficult, particularly when you look at what some legislators and regulators have indicated. I think there is still some suspicion on the part of some policymakers that the clinical quality and efficacy of services received via telemedicine probably does not match that of in-person services, particularly for certain kinds of indications. There's a bias towards keeping telemedicine mostly a rural benefit. There's also a fear of increased costs with expanded telemedicine usage. And quite frankly, a lot of studies that have been done have been inconclusive on the cost issue in particular. And so we're going to need more data to look at cost, how you measure cost. Is it cost over the life of the patient? So there's still a lot of work to be done in that area. The recent Medicare Payment Advisory Commission report really casts a lot of doubt on not only the cost issue, but the clinical efficacy issue of a lot of telemedicine specialties, except for telemedicine involving end-stage renal disease and stroke. But everything else seemed to really catch their ire and their skepticism. So in conclusion, if I had to make certain policy recommendations, I think, again, as I indicated earlier, I think broadband connectivity is a really underrated issue here. You can have all the great telemedicine program design that you have, but if you're not able to access broadband, that's going to be an issue. And with the repeal of net neutrality, it remains to be seen how ISPs are going to react, particularly with regard to healthcare. So that, I think, remains to be seen. I think we need greater Medicare and Medicaid reimbursement for telemedicine, particularly on the Medicare side. There are too many restrictions that keep the Medicare benefit below $30 million out of the over $600 billion that was reimbursed last year. I think we need to rethink licensure. Instead of having concluding that the service occurs where the patient is located, perhaps we should do what the EU does and have the state of origin principle, which means the practice of medicine occurs where the physician or clinician is located. And that way we don't have the licensure complexities that we have today. Would like to see more modality neutral definitions of telemedicine or telehealth, so we don't restrict it to just live video, that it can include secure messaging and all the other interesting technological advancements that facilitate greater communication today. And with that, I'll turn it back over.
All right, well, thank you very much, Renee, and thank you to the panelists. James, you want to just sit over there so I can kind of look at you guys. So we did have a few questions come in from our participants who were joining online. Some were just informational. But one question which I'll put to the group was that, recognizing that the biggest gap in the delivery of our biomedical HIV prevention currently in the United States is African American young men who have sex with men. And as I mentioned, the CDC estimates that about 80,000 people of the 1.1 million who need PrEP, so that's less than 8% of those who need PrEP are actually on it, and those numbers are even worse for African American men who have sex with men. What have you guys thought about in terms of how to enhance participation in the delivery or the kind of community engagement with that specific target population? So, Carol, I'll start with you.
So, can you hear me okay? I believe it's really important to essentially involve those individuals in these interventions. So in the design and the build of these interventions, similar to PrEP Tech, when we went to the community and developed a community advisory board, and really utilize the community to help design the telehealth solutions, as well as to recruit people in their community to bring them. And also coming back to what James mentioned about the word of mouth and how valuable and important that is in getting anyone into certain types of medical care. Just a personal referral means a lot, and I think, for someone who's been involved in PrEP Tech, we had a lot of folks who were recruited through another friend who had also signed up when we were in recruitment of our project. So.
All right, Michael, I mean, your population in Iowa may be a little bit different, but I'm sure there's still very hard-to-reach populations that, remain at very high incidence and risk for new HIV.
Exactly. So the intersection in Iowa is populations with low uptake, poor use of PrEP, African American populations together with rural. And it's a matter of trust. And I think trust is best gained, first of all, through social network referrals, people saying, talking about this is a telemedical provider for PrEP, and you can trust these folks. So you've got to build good stories. You have to build partnerships with the community, with community members, and start to build good stories through that. I think it'll be interesting to see how telemedicine impacts this issue of trust and concern around suspicion and across groups in our society, around stigma, rural-urban divides, which certainly exist in our society now. And on one hand, I think maybe that sitting down with another human being in a room and having that initial interaction is key to nucleating that initial trust in that relationship. On the other hand, I think sometimes, and this is where video conferencing comes in, there can be a critical distance in that interaction around some of these issues where people come in with a lot of concerns and not quite sure about it, that can allow earlier discussions than might be comfortable to have in other settings. And I think that's something that we'll find through trial and error and through getting some evidence back.
All right, thank you. And James, as a commercial entity, you've obviously allowed and adopted Medi-Cal and other kind of Medicaid payment systems. But is there anything specifically you guys think about in terms of to reach the hardest to reach populations who need PrEP specifically the most?
Yeah, I think it's on. No. Thanks. I think there are lots of reasons why certain populations do not have as high utilization of PrEP as others. And a lot of those revolve around stigma and trust, as he mentioned. And that's something we think about a lot. And how can we, fortunately we have the advantage of using digital sort of advertising to reach these people, so we can be very targeted. We can find people easier on social media and through things like Grindr or Google searches to really target those populations who are most in need. So.
Renee, are you still out there? Renee?
Yeah, I'm here.
Okay, good. So is there anything that you've seen in the policy arena with, the federal agencies, really trying to come to this proactively to address the inequities in access or healthcare services? Have you seen anything, that suggests that people see that this may have, better utilization in certain populations, or may, be used to reach those who usually do not access services?
Yeah, and I think I mentioned earlier that there's some skepticism out there, particularly at the federal level, about the efficacy and the cost related to telehealth services. But one area in which I think there's a lot of optimism is the use of telemedicine to treat and address chronic conditions. So I think there is a sense out there that constant monitoring, communication that can be done through telehealth is particularly useful for folks with chronic conditions. So that's the one sort of ray of light I see in terms of federal policy making vis-a-vis telehealth.
All right, thanks. I had another question that came in from the participants about the current requirements generally in most states. I'm not sure how you would interpret Hawaii specifically, but most states require some kind of synchronous real-time video interaction. So we have two physicians on the panel. I'd be curious, is that really required to provide quality services? Should there be, more policy initiatives just to reduce it to a telephone encounter or some other kind of secure encounter? Where does that history come from that requires some kind of video-based intervention? And you can, if you want, you can limit your comments specifically to PrEP. We're not talking about people who may have to present with physical findings or rashes where you might want to actually see some images. So James.
I think it is important to have a video interaction. They don't teach it explicitly in medical school, but reading body language is part of what we do as physicians. And since this PrEP is a topic that brings up a lot of emotions and it's very personal and there's huge issues of trust, we may not all realize it, but those are things that you establish through seeing another person's face and talking with them. And so to me, it is a critical piece of the interaction, and I would be hesitant to do it without seeing someone.
I agree. We're talking about topics with a lot of psychosocial overlay, and nonverbal cues are critical. One thing in our program, we encourage everyone to connect with a primary care provider for holistic preventive care and comprehensive preventive care, because there's some things we know we just can't provide at a distance. On the other hand, we can see ourselves as a point of transition into holistic primary care for a young population that may not have a lot of primary care currently. We also know that we have clients that don't want that. And if PrEP isn't happening through us, then through whom? It may not happen at all. So I think the video is it's better than the alternative, which is nothing. I do think there's something to be gained from in-person care. I'm not sure the physical exam is critically important in most of the cases that we're delivering PrEP. I think ultimately these are empiric questions, and most of the reasons that the regulations are the way they are is historical, just grandfather clauses, and some of these things could be subjected to experiments to determine what is necessary for different conditions.
Yeah, so it just made me think, early on with access to contraception, there was probably the similar mindset among physicians that you wanted to have a face-to-face. They didn't obviously have, video interactions then, but you had to see someone, and, it took us a generation or two to get to a place where we can have over-the-counter contraception or contraception available in vending machines. So I think we may be getting there. Renee, in the policy arena, which is usually, not necessarily proactive, it's reactive, has there been a push to eliminate requirements for certain conditions in terms of the video interaction? Or, I mean, as you said, you know, certain payers, you know, make that kind of absolute necessity in terms of establishment of a patient-doctor relationship.
Yeah, I think video is still considered the standard of care when providing telehealth services. I think there's a recognition by some states that may not be a real-time interactive video consult may not be necessary for all specialties and for all disease states. So some states make exceptions for pathology and ophthalmology. Some do it for psychiatry. So I think we're starting to see some differentiations by specialty and disease state, but that is the exception and not the rule.
All right, thank you. So we have 5 more minutes. I'd like to entertain some comments or questions from the audience. Please.
Hi, I'm Maluba. I love that all of you mentioned the stigma, because I know that a lot of stigma comes with that. Just one comment, and I know, Kara, we did speak about this, but for everybody in the room, I think it's important to have person-first language. I'm a woman living with HIV, but if you call me HIV positive, that insists that the HIV is more important than me being a human. So person living with HIV, person not living with HIV is important. And then just wondering, for those of you who engage with community members or have community advisory boards, how are they, or are they compensated for their time, advice, and consultation?
Yes, for the PrEP Tech study, we had a community advisory board of 5 members, and we provided them with incentives as a thank you for their time. I believe they were gift cards to Amazon.com upon participating and becoming a member of our youth advisory board, community advisory board for PrEP Tech. And then also we had them come in for a few design workshops. And in any instance in which they came in, they also were provided with an incentive. But they also, as community members, were very interested and passionate about getting this information out to their community. So our CAB actually helped us with recruitment and provided some feedback also virtually that was not necessarily linked to an incentive. So I believe, we firmly at YTH believe in the necessity and desire to make sure that people, and young people in particular, are compensated for their time. So as best that we can do that, we try to provide that. But we are really excited to see the excitement within the community as well to engage and try to get other community members involved in the health issue.
So first of all, I couldn't agree more. Language matters, and thank you for pointing that out. Yeah, we, with community members we're worked with, we've paid people to be part of our program with hourly wages and compensation for interviews and things like that, so similar programs.
All right, we have, I think, time for one last comment in the back with a tall hand raised. That's you? Okay, excellent. And we have about a minute or two, so we'll allow the respondents to give brief replies.
This is a question for James. My name is Montika. I run a PrEP program at City Clinic here in San Francisco. So I wanted to ask, and hopefully this is helpful for others in the room as well. So what are the most challenging groups of people to help once they have arrived for PrEP clinical services? Is actually people with private insurance, because there's hundreds of different plans and hundreds of different cost structures, cost sharing structures. So can you speak to what level of footwork your service provides with folks to make sure that their out-of-pocket costs are as low as possible?
So thank you for asking that. That is a great question, and as a doctor, I learned nothing about this while I was in medical school or training, but quickly found out what you are talking about is that insurance comes in a million different variations, and it is something that we deal with. We partially have a tech solution where you sign up for the site and instantaneously you're told what your copay is, And part of what we're doing on the people side is we say, if our system gets that wrong, if we're wrong about telling you what the price is, you'll never get a bill in the mail. We're going to just sort of eat the cost. We'll provide the visit for free. And that's something that, is missing in healthcare, is that piece of transparency. And so we do work with, dozens of different insurers and hundreds of different plans. And sometimes we get it wrong. Hopefully most of the time we get it right. And just kind of believe that people should have that up front, because cost is a big part of this for people to get access. Does that answer your question, I hope? We do enroll people in the copay assistance program and any other assistance program that we can find in their region, area, state, et cetera.
All right, well, I'm afraid because of the hour, we're going to have to wrap up. But thank you very much. I want to thank SAFE also for helping co-sponsor the lunch for today. And the SAFE app is available at safeapp.me. Something to learn about and investigate a bit and perhaps share with your friends. I want to thank the panel for their travel and their participation. And thank you, Renee, for calling in from Washington.
Thank you.
So as we move into the final afternoon sessions, please take all of your belongings.